Hello and welcome to my opthal teacher. Starting with the treatment of glaucoma, I'm going to talk about the non-surgical management of glaucoma, that is mostly the medical management and the laser. So now you might come across this term target pressure if you read about glaucoma medications or glaucoma trials for that matter. So what is this target pressure about? Know that the normal population has an IOP in the range of 14 to 17 mmHg. Now we've got this figure from statistics applied to a large number of population. So the upper and the lower limit is actually 10 and 21 mmHg, which you might find in book, and this is the statistically normal IOP seen in the population. Now, so what is target pressure? This is the normal intraocular pressure. Target pressure is basically a range of intraocular pressure, not one pressure, but a range of intraocular pressures at which further progression of glaucomatous damage does not occur. So this is the easiest and the simplest, definition of target pressure. It depends on several factors. Of course, it depends on, there are so many risk factors. So you might want to set a lower target pressure for somebody who has thin CCT, etc. So there are, it depends on the risk factors, and of course it depends from patient to patient. For example, in an older patient, right, you might want to set a lower target pressure in an older ocular hypertensive, for example, right? So it depends from patient to patient. It also depends on the race of the patient, right? A simple rule of thumb to remember, if you can, is that for early disease, just aim for 15 to 17 millimeters of mercury. For moderate, 12 to 15, and for severe, you have to aim in the lower teens, that is 10 to 12 mmHg, or sometimes even less than, even 8 to 10 mmHg for that matter. If not, if you cannot remember that, you can remember the figures 30% and 40%. These have been, given by some landmark trials in glaucoma. CNTGS stands for Collaborative Normal Tension Glaucoma Study. AGIS stands for Advanced Glaucoma Intervention Studies. So these are very big landmark and very important trials. So they have given some pressures, such of some, thresholds such as 30%, 40% reduction from the baseline IOP if you find that the glaucomatous damage is significantly progressing. So now that we know about the target pressure, that's the most important thing. Let us talk about the medications that reduce the intraocular pressure. Now we know that intraocular pressure is the only modifiable risk factor. So whatever we are doing to lower the intraocular pressure to such a level that it does not cause pressure-induced damage of the optic nerve, because glaucoma is an optic neuropathy after all. So what are the two types of medications? We have medications that decrease aqueous production. These include beta blockers, alpha agonists, and carbonic anhydrase inhibitors, and those that increase aqueous outflow, which is cholinergic and prostaglandin analogs. That's the salt, the various salts and the various groups of medications, right? Now there are certain brand names, some very popular ones. So I think you should get familiar with the brand names. That's Lumigan, Zalatan, then there is Travatan, then pilocarpine is not used so much. But beta blockers, for example, we have Timolol and so on. Then Alphagon, you have Azopt, and of course the oral carbonic anhydrase inhibitors, Diamox, right? So it's good to familiarize yourself with some of these. But yes, of course, you have to know the name of the medication. So, site of action. Now, this is just a diagrammatic representation showing what the angle looks like. Okay, and I've shown the various receptors in black, right? So let us begin. Now, miotics. Miotics are not used in primary open angle glaucoma anymore. They are the drug, not exactly the drug of choice. They are a temporizing measure of angle closure glaucoma before you plan, say, a laser iridotomy or maybe a surgery. So, in angle closure glaucoma, miotics basically act here on the sphincter pupillae. They pull the iris, the peripheral iris, away from the angle, thereby opening up the angle, right? So, what are the receptors? The receptors are the M3 receptors, right? And the drug is pilocarpine. So this is how it helps in angle closure. In open angle glaucoma, for which it is not really used anymore, how does it act is that it contracts the longitudinal ciliary muscle, right? M3 receptors are present here also. In doing so, it pulls on the beams of the trabecular meshwork, right? And it opens up the trabecular meshwork. So that is how it reduces the intraocular pressure, opening up the trabecular meshwork and increasing the aqueous outflow. So that is the mechanism in open angle. It's not really used, okay, pilocarpine in open angle. Next, comes the other group of drugs which are going to act here on the non-pigmented ciliary epithelium, which is the site of production of aqueous. So we have beta blockers and alpha agonists, right? So there have to be receptors. So we have beta 2 receptors, which are the predominant beta receptors in the eye involved in intraocular pressure regulation, alpha 1, alpha 2, and of course we have an enzyme known as carbonic anhydrase, all of which are present here in the non-pigmented ciliary epithelium. So these drugs, the beta blockers and the alpha agonists and the carbonic anhydrase inhibitors, they act here on the epithelium of the ciliary body. Then we have prostaglandin analogs. Where do they act? They act on the uveoscleral outflow. They increase the uveoscleral outflow. Where do they act? They act on these prostaglandin receptors present within the ciliary muscle. They are also believed to act on the episcleral vascular, vascular flow, increase the outflow, something to do with the episcleral vascular channels also. So this is the site of action of prostaglandin analogs, that is the ciliary muscle, and they work by increasing the uveoscleral outflow. Recently, we have drugs. Now, you know that uveoscleral is the non-conventional one, right? That it is the trabecular outflow, which is the conventional outflow. That is 70% of the aqueous outflow. So, there are limited drugs which are acting here on the trabecular outflow. We'll be talking about it when we talk about some novel drugs which are available now. Adrenaline acts upon this particular outflow, but it is not available in the form of eye drops and not used also, of course. So that is to begin with. We're talking about prostaglandin analogs. Prostaglandin analogs are the gold standard now. And how do they act? They increase uveoscleral outflow, as we saw in the previous slides. They reduce the IOP. Now you have to remember this IOP reduction caused by each and every class. That's important at your level. So reduce IOP by 25 to 35%. This is the maximum, right? All other classes of drugs reduce IOP up to 25%. Prostaglandin analogs do it up to 25 up to 35%. All right, so they are the first line drugs. They include latanoprost. Must remember the percentage: latanoprost 0.005, travoprost, bimetoprost. I've highlighted travoprost and bimetoprost because they are available in preservative free forms. Okay, preservatives are a very notorious thing when it comes to anti-glaucoma medications. They cause a lot of ocular surface problems, so it's good to have preservative free drops, and these are available in the market. Administration of prostaglandin analogs is once a day, preferably at bedtime. Hardly any systemic side effects, but a lot of local side effects, which can be managed. And a problem is that they are costly. Okay. So side effects, remember the H's. So H, the 1, 2, 3, 4 stands for all the H's. One, hyperpigmentation. Look at this. Look at this eye around the skin. The hyperpigmentation of the skin surrounding the eye, right? Look at the skin over here, right? Hypertrichosis. Hypertrichosis means an excessive growth of hair, especially when talking about the eyelashes. So if you compare both the sides, look at the eyelashes on this side, right? These are caused by the prostaglandin analogs. Heterochromia iris. So it has increased pigmentation in the eye in which the eye drops are being instilled. So there is increased pigmentation over here. Herpes exacerbation. So they are relatively contraindicated in cases of inflammation, in cases of a history of herpetic uveitis. And this is a problem, cystoid macular edema. More so if given perioperatively, that is before or after cataract surgery. So they are best avoided before and after cataract surgery because they cause cystoid macular edema in those cases. Now, these are the points that you must remember about each and every drug. This is not an exhaustive lecture. It's just for the basics. For example, if you want details of how they increase the uveoscleral outflow and you want the name of the receptors and everything, you have to go back to the books and read. And I would highly recommend Shields for that matter. So anyway, just the important things, just to clear your concepts. Then we have beta blockers. Now, beta blockers came before prostaglandin analogs, and they used to be the gold standard earlier until prostaglandins came into the scene. So, beta blockers, how do they act? They decrease the aqueous production, reduce IOP by 20 to 25%, but tachyphylaxis, that is, a plateauing of the effect, is seen in up to 10% of the patients. They have an additive effect with the systemic beta blocker, so the effect of IOP reduction would increase, would add up, so would the side effects. They are less effective and best avoided at bedtime. Why less effective? Because at bedtime, the aqueous production is not really at its peak. So anything that reduces the aqueous production will not work as well. And best avoided at bedtime because they have a problem. If they enter the systemic circulation, they're going to cause hypotension and lead to decrease in ocular perfusion, further, damaging the optic nerve. So that is why best avoided at bedtime. May be preferred in unilateral glaucoma for cosmetic advantage. You saw how the prostaglandin analogs are causing hyperpigmentation and hypertrichosis if applied only to one eye. So in such cases, you can give beta blockers. Ocular inflammation, where you cannot give prostaglandin analogs, cystoid macular edema, and herpes simplex keratitis. So conditions in which prostaglandin analogs cannot be given, you can try beta blockers. So topical side effects are not much, but a lot of systemic side effects. You have to know, very, very important. That's why I put it in red over there. So beta, especially timolol, the non-selective beta blocker. So beta, because of beta 2 blockade, it's going to cause bronchospasm. That's why relatively contraindicated in asthmatics, heart block patients, bradycardia, hypotension, peripheral vasoconstriction mediated by the alpha receptors, and then some receptors in the CNS also causing fatigue, depression, sleep problems, loss of libido, so on and so forth. Very, very important systemic side effects. Names and concentration of these drugs have to be remembered. So timolol is beta 1, beta 2 it's basically a non-selective one. The most commonly used concentration is 0.5% given twice daily. Gel-based preparations for one's morning dose are also available. Betaxolol is also twice daily. That's the concentration. Lower hypotensive effect than timolol because betaxolol is a relatively cardioselective, that is beta 1 selective, right? And the predominant receptors in the eye are beta 2, right? So less effective than timolol, but it is neuroprotective. Remember that there are a few neuroprotective anti-glaucoma medications. Betaxolol is one. And of course, it causes less bronchoconstriction since the beta 2 effect is not there. The beta 1 effect is there, which is more selective for the heart. So less bronchoconstriction. Then we have levobunolol, which is a long-acting beta blocker, and then there is cartiolol, which has a more selective ocular action, hence less systemic side effects. And this is the one which is said to have an intrinsic sympathomimetic activity. So that's the beta blockers for you. Then we come to alpha 2 agonists. Of course, they increase the aqueous production, but also know that they increase the uveoscleral outflow by mechanisms that are not really clearly understood. Reduce IOP by 20 to 25%. These are also neuroprotective. The problem is that they cross the blood-brain barrier, so they are best avoided in children. They are avoided with MAO inhibitors and in vascular insufficiency because they cause alpha mediated vasoconstriction. Allergic conjunctivitis is a common side effect, right? And anterior uveitis is a rare side effect. It causes a granulomatous sort of anterior uveitis. You see these KPs over here. The systemic side effects include dry mouth and fatigue. So that's the two popular alpha 2 agonists. Brimonidine 0.2% twice daily. Apraclonidine 0.5 to 1% is available. Apraclonidine is the one which is used for short-term control of IOP, usually during laser procedures. So that's alpha 2 agonist summarized. Topical carbonic anhydrase inhibitors. We know that carbonic anhydrase is an enzyme present in the non-pigmented epithelium of the ciliary body and is responsible for aqueous production. So carbonic anhydrase inhibitors decrease the aqueous secretion, reduce IOP by 20%. They are also said to be neuroprotective, especially when added with beta blockers. So that's the third type of drugs which in conjunction with beta blockers are neuroprotective in nature. The dose of carbonic anhydrase inhibitors is thrice daily if used alone, twice if used in combination, usually with a beta blocker. The problems are that they cause corneal decompensation and they are usually contraindicated in eyes which have any kind of endothelial compromise. Systemic side effect, idiosyncratic bone marrow suppression, contraindicated in sulfonylurea. The latter are rarer side effects, but yes, this has to be remembered. They're absolutely contraindicated in eyes with endothelial compromise. No additive effect with systemic carbonic anhydrase inhibitors, that is Diamox, unlike beta blockers. So we have dorzolamide 2%, brinzolamide 1%. Dorzolamide has some side effects such as a stinging sensation on instillation, transient bitter taste, which can be avoided with punctal occlusion, and rarely allergic blepharoconjunctivitis. Very, very rare. Brinzolamide is said to have relatively less side effects. The last group of drugs is meiotic. Now, of course, I'm talking about the conventional drugs. So, how do meiotics act? They act in angle closure, they act by causing meiosis and pulling the peripheral iris away from the angle, thereby opening it up. In open angle, they cause, contraction of the ciliary muscle, thereby opening up the trabecular meshwork. So not really used in open angle glaucoma and not very, very used for only a short while in angle closure glaucoma because they have this battery of side effects. So local side effects, brow ache because they cause ciliary spasm. It is for this reason that they are contraindicated in very high myopes because there is a risk of RD. Myopic shift, they affect cataract. Obviously, if there is a meiosis and there is a central cataract, the vision is going to be affected. And for the same reason, visual fields are also affected. Systemic side effects are rare but include confusion, bradycardia, bronchospasm, gastrointestinal symptoms, and urinary frequency, all mediated by the cholinergic receptors. Right? They reduce IOP by 20 to 25%, but very use is limited because of the side effects. So the concentration of pilocarpine 0.5, 1, 2, or 4% 4 times a day, and alternative is carbachol. So that's about meiotics. So now that we've talked about the conventional, drugs, let us just briefly try to understand how to approach the target IOP. So in the beginning, I told you what target IOP should be, right? So how to start the medications. So basically, if you find that the baseline IOP is say 21 22 mmHg, you can start with a prostaglandin beta blocker. Prostaglandin beta blocker are still the first line drugs. So you observe for a period of 2 weeks. So that's when the peak action happens. So wait for 2 weeks or say 10 days. So switch one or two drugs. So see, when the baseline is not so much, the pressure is like 20, 21, 22, 23, you can still, switch to an alternative therapy. You have time for that. So switch one or two drugs. If no response, wait for another 3 to 4 months. Not happening, you add a drug. All right. That's how you approach a baseline of less than 25. If a baseline is between 25 to 30, again you start with the first line drug. You wait 10 days, you add one or two drugs if required. If you're not able to achieve the target IOP, you wait for 3 to 4 months, right? So you can still wait if the pressures are below 30 mmHg. You can wait for 3 to 4 months for the target IOP to come. The peak action itself takes 2 weeks, right? If the baseline is 30 mmHg, only prostaglandin beta blocker, not a good idea. You give that. Plus, any IOP above 30 mmHg has to be immediately brought down. So you use Diamox for 3 days. Diamox is, we've talked about Diamox and mannitol, so I've not discussed it, the two in this particular lecture. So they are used for acute lowering of IOP, acute and rapid lowering of IOP, right? So you have to add Diamox for a few days. You wait 10 days, add brimonidine, then you have to add, obviously a single drug is not going to work if for IOP greater than 30 mmHg. So you add brimonidine or carbonic anhydrase inhibitors or both, and then you look for IOP decrease. So this is how you approach, right? When the patient walks in. After that, so basically, if you find that the target IOP is achieved, well and good, you keep reviewing the patient every 3 to 4 months, and you have to keep taking the IOP readings, and you have to keep in mind the CCT and the corrected IOP, of course, all of that. And then, every 6 months, you follow up the patient, or maybe a year, depending on the progression, you follow up the patient with pressures, optic disc evaluation, perimetry, and OCT RNFL if required. So you do that. Now, if after 3 months the target IOP is not achieved, or the patient belongs to a poor socioeconomic status, or is likely to be lost to follow up, you go and do a definitive surgery, that is trabeculectomy. I'm going to talk about the surgical management in the subsequent lecture, or you refer the patient, right? Refer basically means it's either going to be a trabeculectomy, or it could be you know, a tube shunt, or maybe some adjunct procedure such as a minimally invasive glaucoma device or something like that. Okay. So, now that we know that you may require multiple drugs for a very, very long time, so compliance is an issue, right? Always in glaucoma patients, you have to have a very, very compliant patient so that the glaucomatous damage does not progress. So the combined preparations came, right? So the good thing with combined preparations is that, first, of course, they have an additive effect, better compliance, and the cost effectiveness is also there, right? So it saves money also. So just some combined, the brand names of some of the combined preparations. So COSOP contains these two, administered twice daily, and similarly we have Zalacom, a prostaglandin and beta blocker combination, then an alpha agonist and beta blocker, again a prostaglandin and beta blocker, then an alpha agonist and a carbonic anhydrase inhibitor. So this is one that does not contain the beta blocker timolol. So and of course how they are administered, I've just mentioned that over here. So it's good to have combined preparations also. Now, there are some novel drugs and delivery systems. So, talking about the novel drugs, so the ones that I've highlighted in pink, they are the novel drugs. Now, why are they novel? So, in the beginning, when I showed you that slide on the mechanism of action, we saw that there were not many drugs that are acting on the conventional outflow, right? The trabecular meshwork. So this is where the novelty comes. So these agents known as Rho kinase inhibitors, they decrease resistance in the trabecular meshwork outflow pathway. They have something to do with the extracellular matrix in the trabecular meshwork. So that is why they are novel, okay? Rho kinase inhibitors. They're already available in the market. It's a slightly old slide. Then the other drug is latanoprostene bunod. It's basically a cousin of prostaglandin analog. And why is it novel? Because it's increasing aqueous humor outflow not just through uveoscleral but also through the trabecular meshwork, right? So that's the novelty of these drugs, and that is why they are more effective than the gold standard latanoprost alone, right? So the ones that are in pink are already available in the market. And of course, it's good to know that of the names of the other drugs also, if possible. Long-acting sustained delivery for glaucoma management is being studied still in trials. So this is what we are using, right? We're using drops. But more recently, some, depot preparations are available. So these preparations can be given in the form of an injection, a subconjunctival injection, a suprachoroidal injection, intracameral, intravitreal, a microneedle, transscleral, controlled release, drug-loaded microspheres which are given intravitreally, microparticle-loaded bioerodible implants. So basically, if you get a long question on the medical management, you can just add a paragraph on this, make a diagram maybe, or this is good for your short notes also. So this is just something that is, this is the recent advance, right, as far as the medical management is concerned. Now, technique of installation of glaucoma medications, very, very important. As ophthalmologists, as non-ophthalmologists, medical doctors, you must know that these drugs, this is how you instruct the patient to put the anti-glaucoma medications. You pull the lower fornix a little bit, you instill only one drop of the drug, and then you do this. This is what is punctal occlusion. Basically, an occlusion of the nasolacrimal duct. This prevents the systemic absorption of the drug. So this is a very, very important. As doctors, you must know, and you have to counsel your patients to do this, please. Okay, punctal occlusion, right? Now, coming on to laser treatment in glaucoma. So what's the principle? The principle is that you have to, you are doing something here in the trabecular meshwork using a laser, something that is increasing the aqueous outflow, right? Right? So you're working on the conventional pathway. So as far as the efficacy is concerned, they are as effective as drug therapy, and they are often used as adjunctive. They are used in that period of transition, maybe between medical to surgical therapy, right? So that's when you use lasers. And recently, lasers ALT is even being considered as a first line management. So let's just look at the mechanism of action, poorly understood, but this is what it is. So the laser is given. What does it do? It does some thermal damage to the trabecular meshwork, which in turn causes collagen shrinkage, stretching of uveoscleral trabecular meshwork, opening up of the trabecular meshwork spaces, increasing outflow. This is one. and this usually works for the argon laser. Another mechanism, laser energy causes release of cytokines from the trabecular meshwork, mostly the pigmented trabecular meshwork, alterations in the extracellular matrix. It recruits leukocytes. There is increased phagocytosis, as a result of which there is some stimulation of the endothelials of the Schlemm's canal, more aqueous outflow happens. Right? So these are the postulated mechanisms of action. Now, just a few more slides, a few basics, a very basic idea of lasers and glaucoma. So the technical word is laser trabeculoplasty. It is of two types: argon laser trabeculoplasty or selective laser trabeculoplasty, and more recently there is a micropulse laser trabeculoplasty or MLT. Okay, which instead of a continuous laser, short pulses of laser are used. Right, so less collateral damage happens. That's one recent advance in lasers. So what is the lens use? The traditional lens is the Goldman 3-mirror lens, okay? But there are special lenses also available. That's the Rich 4-mirror or the Latina single mirror. This one's Latina single mirror. So the use of this lens or of these lenses obviously is to visualize the angle. You have to, you can easily rotate the lens 360 degrees and easily visualize the angle where you want to give the treatment. It has to be very specifically directed at the pigmented trabecular meshwork. So that's where the lens comes into use. And of course, the lens also helps to prevent dissipation of the laser spot, right? It avoids all that reflection and all, and it gives a clear laser spot so that you can just apply the laser energy on that specific area of interest. So parameters for argon laser. This is the power, 300 to 1200. So what do you want? You want a slight blanching or a small bubble, nothing more than that. You don't want to burn it. The spot size in argon is 50 microns, and remember, it should be at the junction of the anterior non-pigmented trabecular meshwork and the posterior pigmented trabecular meshwork. Okay. Duration 0.1 second. Number of burns 30 to 50 spots over superior or inferior 180 degrees, and the other side in the next sitting. So see, argon laser, just a schematic. You see, this is the lens placed on the cornea. That's the mirror over there. So the laser energy gets reflected by the mirror, right? So again a type of gonio lens only, right? So the laser energy is specifically directed to the trabecular meshwork over here. So this is a real view from inside the eye, a view at the angle. So the spot that you see here, this is the argon laser, right? The 50 micron spot. And this is the SLT, or the selective laser trabeculoplasty. It uses lesser energy and it is selective. Why? Because it is specifically directed at the pigmented trabecular meshwork, right? It is not on the non-pigmented. Whereas this one, you see, this is at the junction of the pigmented and the non-pigmented, right? So this is the ideal placement, that is between the non-pigmented, that is the anterior, the non-pigmented, and the posterior pigmented. So it has to be in the middle, right? Not too posterior, not too anterior. So this diagram is just to emphasize on that. Selective laser trabeculoplasty. Now, it selectively targets the pigmented TM cells. No thermal damage happens to the non-pigmented trabecular meshwork or other structures. The laser used is a double Q switched Nd:YAG laser, unlike an argon laser. Pulse 3 nanoseconds. Power much less. That is, it was 300 to 1200 milliwatts in that case, in the case of argon, whereas it is much less in this case. The spot size is larger. I'm sorry, I correct myself. The spot size is larger here. It's 400 in SLT, whereas 50 microns in ALT. As you can see here, see larger spots applied to the, pigmented trabecular meshwork over here, and smaller spots applied here at the junction of the pigmented and the non-pigmented. So basically touching as little of the non-pigmented trabecular meshwork as possible. Okay, again, the larger ones, that's the ALT over here, and these smaller spots are the SLT, right? These small again, the larger spots here are 400 micron spots. These are the SLT, specifically at the pigmented trabecular meshwork, and the smaller spots are the ALT spots. Okay. So just a comparison. In ALT, that is argon laser, this is the frequency of the laser used. That this one's an argon, this one's Nd:YAG. Then the spot size 50 in microns, and ALT is at the junction of the TM and PTM. Small spots given at the junction of PTM and non-pigmented TM, whereas here large spots given on the pigmented TM, right? Then duration 0.1 seconds, 3 nanoseconds, power 300, more power in argon laser. That's why more thermal damage, more collateral damage happens. Selective laser, less power and less thermal damage. That is self-explanatory. Now, indications of laser trabeculoplasty: primary and secondary open-angle glaucoma, including exfoliation syndrome and pigmentary glaucoma. Now, there are some relative contraindications, where you cannot visualize the angle properly. Obviously, you will not do a laser in cases such as patients of ice syndrome, or patients with an extensive uh, peripheral anterior synecdoche, all 360 degrees pass, completely closed angle. Obviously, you cannot see the structure, so you're not going to do a laser, right? So these are obviously very logical things. Obviously, it's a contraindication. Then ocular hypertension, alternative to medical therapy in cases of failure, poor compliance, or adjunctive. And it is found to be equally effective to a monotherapy, right? Some precautions. So these procedures are associated with a transient IOP spike, hyphema, and iritis, right? So you have to take care of these things. These are more so with the argon laser because of more of thermal damage happening. So precautions: a drop of apraclonidine or brimonidine instilled 30 to 60 minutes pre and post procedure to prevent a post laser IOP rise. Then topical steroids 4 times a day for 1 week is prescribed post ALT. Again, why? Because more chances of these kind of inflammations are there because of more thermal damage. And always check the IOP 30 to 60 minutes post any laser procedure in order to check the IOP rise. Okay. So I've just touched upon the basics of non-medical management of non-surgical management of glaucoma, and this is going to be very good for your revision. But then, of course, when if you want to, read extensively, you have to please refer to a reference book. Okay. So thank you, and stay tuned for surgical management of glaucoma.